So the principles are the same. So we saw that there is a poor or moderate agreement between MRI and biopsy and the final pathology. So because of that, there is some concerns about the oncological safety of focal treatment if you only consider MRI and biopsy and how we need to try to look these patients. So the design of the study are the same, the database are the same, but we consider in that case that as a criteria for eligibility for focal treatment, patients with unilateral, localized, and ISUP 2 or 3 disease. So what you find, in most part of these patients that will underwent radical prostatectomy, about 66% of the patients are ISUP 2 or 3, only 70% of the patients have bilateral disease. So the most part of these patients who underwent radical prostatectomy are able to performing focal treatment. But if you look and if you think that you agree that most important are the pathological findings of final specimens, the most part of the patients in the analysis of the prostate have bilateral disease. Only 63% of the patients have organ-confined disease. In the beginning, we classified as localized in MRI, but in the final, 77% of patients are T3A or T3V. So if you look for the criteria of eligible for focal therapy, and you look only for homolateral biopsy, the most part of the patients, 76% of the patients are eligible. But if you consider the results of contralateral sampling, only 60% of the patients will be eligible for focal therapy. But if you consider the final specimen, only a small amount of these patients, 18%, will be eligible for this kind of treatment. So probably MRI and biopsy is not enough if you consider the only way to classify these patients for focal treatment. But I think the most important now is considering if MRI invasive lesions is so important to treat. Okay.